Dr. Dave Howells is a consultant psychiatrist in Cardiff and Vale Health Board. And Dave has very kindly agreed to present on a very topical subject that's still somewhat controversial, and that is medical cannabis. So Dave, over to you.
Well, thank you very much for that, and Diolch Fawr, have a bit of a discussion and try and explain, why I feel this is an important topic to bring to the conference today, and thank you very much for having me here. By way of disclosure, I'm a co-founder in a cannabis clinic, that's Cannabis Clinic Cardiff, and as I say, I do that on a part-time basis alongside my regular role as an old age psychiatrist. I suppose the one thing which I wanted to get across today was the fact that we have a situation whereby we're 50 years or more behind the academic research into this area. Due to prohibition, the ability to study cannabinoid medicine has been severely impaired. We've only recently had cannabis-based medicines rescheduled from a Schedule 1 substance, which has no medical benefit whatsoever, to a Schedule 2 substance, which may have medical benefit, which can be researched. So that's our kind of starting point. And this was changed in late 2018 when a large campaign via the parents of children with intractable epilepsy syndromes who found that the benefits of a cannabinoid-based medicine were so substantial that they were willing to risk criminality and arrest in order to get their children the medication that they felt they needed. That would be a fine anecdote, and I'm sure any one of us would wish to do whatever we needed to do for our loved ones. So what we have is our BNF. That's where we start from. In there are over 1,600 different medications, and only 3 of those are medications which address the endocannabinoid system. So within the body we have an endocannabinoid system with enzymes and chemicals and receptors, all of which have been a part of animal evolution for over 600 million years. So we're starting from a point that our body is hardwired with an endocannabinoid system which will react with chemicals that fit the lock and key. So from very much sort of a primordial basis, we have that system in us. Now, out of the 1,600 medications in the BNF, we have 3 which address this. So we have 3 medications, one which has THC in it, one which has CBD in it, one which has a combination of both. The medication that has this CBD, the cannabidiol, which is sold over the counters up and down the country, is the one they use for epilepsy and potentially has effects in other neurological disorders. So that's not a psychoactive substance. And on the other side, we have the THC, which is the part which we worry about in terms of psychosis and anxiety and depression, etc. And that's the part people do seek out on a recreational basis. So we have within our armoury, 3 medications with 3 conditions, which are pretty limited to how you can prescribe them. For anyone who has been to their pharmacist and said, would it be worth trying this? The response is universally, no. Have you tried the other licensed medications, other medications which have a license for the condition you're seeking? And in psychiatry, we are accustomed to using medications that perhaps are off license, that perhaps haven't got as much an evidence base, or if they do have an evidence base, do have some fairly severe side effects. I know from my practice as an old age psychiatrist, I regularly prescribe medications to, say, people with dementia, vulnerable people, which are very dangerous. I discuss those risks with the patient, with their family, and we try and get to a point whereby the risk-benefit analysis is weighted in the side of benefit, and we have that as a trial. So we're used to these kinds of conversations, and as medics, I would argue that we're ideally placed to be making these sorts of decisions. So that's That's why I think it's important we perhaps have a rethink on the medications we already have, and then potentially think a little bit wider as well. So, in terms of the endocannabinoid system, what we have is two main receptors. There are other receptors, but we've got our cannabinoid 1 receptor and our cannabinoid 2 receptor. And the cannabinoid 1 receptor is primarily found within the human central nervous system, but also elsewhere. And cannabinoid 2 is primarily within the immune system. As chemicals themselves, there is a growing amount of research into these compounds, preclinical research, which shows that they're potent anti-inflammatory drugs, they're antioxidant, anticonvulsant, as we've mentioned, and because it's got a wide-ranging effect, there's also evidence that it's useful for pain, for sleep, and also for stress reduction, and particularly CBD on a neurological basis has been associated with neurogenesis. So, actually the regrowth, particularly in the hippocampi, which is for an old age psychiatrist quite an exciting situation. Outside of psychiatry, there are also studies going on in terms of cancers. The ones which are showing great potential benefit can include the brain tumours, astrocytomas, and there's also research coming out of particularly Israel on breast cancer and prostate cancer. Far too early to be recommending these medications, but it's quite exciting that this area of medicine is suddenly found a renewed interest. We've established that we have an endocannabinoid system. We've had this for an awful long time, far, far longer than the cannabis, the plant, has been around in existence. So cannabis, the plant, with its phytocannabinoids in, is addressing a need within the human body we already have. These are chemicals which interact with our endocannabinoid system, and so that's how they have their effect. They contain many, many, many different cannabinoids. We talk about the THC and the CBD, but actually there are a lot more of those. Those just happen to be the ones that are most well known. And there are other chemical constituents within that plant anyway, so it's messy. Cannabis as an extract, as a product which people use in an unrefined, unisolated state, is messy. And so as scientists, we like our placebo-controlled trials. We like to be able to compare a known thing with another known thing. And when you get down to it, this is not the case with cannabis-based medicines. Each chemovar, each genetic copy of a certain cannabis plant will have a pattern to it, a signature, but also the way in which it's grown and tendered and dried and extracted all have their own constituents as well. So even a single strain of a cannabis plant could have many potential variations on them. When people look at the BNF and they see these isolated molecules, and that's quite understandable, why would anyone suggest that we use a cannabis plant as opposed to that pure medication? And the answer comes out in what's called the entourage effect. And this is a somewhat controversial concept, but the concept is that the combination of the chemicals in whatever order has a greater effect than single isolated compounds themselves. And there is some evidence towards this, and this is why some of the parents of the children with epilepsy are so fervently demanding to have the cannabis extracts rather than the isolated CBD molecules. So again, we're talking from an anecdotal basis rather than a strict scientific basis. But you and yours have intractable epilepsy. You want to go with what seems to work for you and your family. Now, cannabis-based medicines are certainly not without their risks, and the one we all think about is psychosis, and we have all seen it when we've been on call and with our patients that people intoxicated with cannabis can have a psychosis. The causality is again a controversial topic, but I think that yes, it can bring on schizophrenia earlier, can make it more intense, can make outcomes more severe. So yes, we have to recognise that this is a great potential risk. However, there are other medications within our BNF which also have that risk. So just because I think this is a potential problem, under medical supervision, that greatly reduces those risks. Other things we wouldn't want is for someone who's pregnant to be using these sorts of medications. We wouldn't want people to be driving if they were intoxicated, just in the same way you wouldn't want anyone driving if you were tired or were over the limit on alcohol, etc. So there's risks here. We do certainly want education of the public to know that younger people are more at risk for this, and that it can result in delayed cognitive impairment for them. Cannabis can be a dependency-forming substance itself, about 9%. When we look at alcohol, that's about 15% of users, and tobacco is a third. So that's quite large, and people do get a withdrawal syndrome as well. It's estimated about 50% of people who are regular cannabis users will have symptoms of withdrawal, and this can explain some of the attitudes amongst people who say they feel worse when they don't have their cannabis-based medicine. So they feel worse, they take the medication. Well, it's working because I'm feeling less anxious, when in fact the anxiety could be the withdrawal. So we have to acknowledge that even if people are taking it for anxiety, is it actually making the problem worse in terms of that dependency? It is a euphoric substance. Again, we prescribe other euphoric substances, and people can get a severe vomiting illness because of it. So it's worth acknowledging that cannabis-based medicines are not without their risks, but in the same case, there are people who believe that there is sufficient evidence for cannabis-based medicines to be prescribed. Professor Mike Barnes, who was one of the original prescribers for childhood epilepsy, did provide a report to the government suggesting that there was good evidence in certain situations. This evidence base is by no means perfect, and certainly it's not sufficient for regulatory and governing bodies to come out in favour of it, such as NICE, and indeed the RC-site position has been a relatively conservative one. So it doesn't necessarily pass that threshold, but given that it does have a fairly good safety profile and patients feel that other medications have not helped them, they are now legally able to go to a clinic and say, I wish to try this medication for my disorder. And so long as there is a sufficient evidence base and it's worth trying, then specialists are able to prescribe this. Whilst there is some evidence for some of those conditions just mentioned, the conditions mentioned here have a lesser degree of evidence, but still there is some evidence there. And interestingly, with CBD, there have been some studies that show it has a potentially comparable efficacy profile than some antipsychotics. So actually, part of the cannabis plant, the CBD part, could actually function as an antipsychotic, which I think potentially very exciting if we think about the potential fewer risks of that. There's also some evidence for its neuroregeneration properties in traumatic brain injury and stroke. And the potential for this to be used in neurological disorders is very exciting. And what we have is, over the last 5 years, maybe 10 years, a real upswing in the number of studies that are being done around the world into this subject. So I think we are at the bendy part of a hockey stick of research into these compounds. And I am so welcoming of that, just so that we have the evidence base to say where we should and perhaps shouldn't be prescribing these medications. So cannabis-based medical products have been legal since 2018 under an unlicensed specials process, which enables hospital specialists and hospital specialists only to prescribe medications which have met strict standards of quality and consistency. So it's a much removed product from those currently taking medications from the black market, with its myriad of potential problems there. Hospital specialists can prescribe in their field of expertise if other approaches have not been effective. And part of the safeguard is to have a discussion around these cases with another specialist and to have ongoing monitoring with that. Part of the regulations as well recommend that users are registered, and Drug Science, led by Professor David Nutt, has put together Project 2021, which is a registry of medical cannabis users, and they undergo regular monitoring in order to try and build a real-world evidence base to try and see whereabouts there are potential benefits and potential harms. Professor Barnes, who prescribed the first epilepsy patient, set up the Medical Cannabis Clinician Society and runs regular education sessions for clinicians who want to explore this area or just who have an interest in this area. So the infrastructure is starting to be there. Internationally, there is a change in a lot of the Western attitudes towards these medications, and particularly when we're looking at Canada and America, they have relaxed their laws in terms of medical and recreational use, and so there's a groundswell of research coming out of there, and being able to look at their experiences can also guide ours. They're not perfect, and every country which goes through this process is doing it in a slightly different way. I'm not sure any of them quite have it right yet, but we have to deal with the situation we're given. There's an estimate that 1% of a population may take cannabis-based medicines if medical cannabis laws are relaxed, which they are. This goes up markedly to getting on for 10% in Israel. So we're looking potentially, 1% or more of the population, which for the UK would be getting on for 700,000 people. That's a lot of people. The graph here shows the anticipated upswing in take-up of medical cannabis. It's not quite that quick. I think we're currently at the 2020-2021 levels rather than at the 2022 level, but it's here. There's approximately 16 companies within the UK now offering these services for both physical and mental health conditions. And so this is something which is going to be something the public are more aware of. We should be more aware of this as well, and be able to talk to our patients about it and to talk about the latest evidence base for it, because this is something which people are able to access in the private sector and potentially one day in the NHS. So with the increasing availability of medical cannabis, there are more studies now going on in the world, and these are anticipated to grow as well. For psychiatry, the primary uses appear to be within the anxiety disorders, and there have been studies, and these can now start to be put into systematic reviews and meta-analyses and suggest that potentially there is a use for these medications here. But as I said, it's really quite difficult to separate out the isolated compounds studies and then the quite messy cannabis-based medicines studies. There's a lot of different variables, and it does take a long time to try and piece these things apart, and potentially decades may go by until we have a real answer on this. But as an old age psychiatrist, the fact that some of these medications may be used for what I consider the most difficult problem we have, which is aggression and agitation in dementia, it does fill me with some hope that potentially we could find an alternative to the medications we give at the moment, which do have side effects and do have significant risks. And I'm also excited that potentially some of the preclinical research may one day provide some hope for people with the underlying disease of things like Alzheimer's and other neurological conditions. There is evidence that the CBD particularly does the sorts of things you would want a medication to do. But obviously it's far, far too early to be recommending these sorts of medications without correct research behind it. So to summarise, cannabis-based medicines, although we have isolated compounds in the BNF, they are very limited, and cannabis-based medicines in general are complex botanical medications with many, many variables that is very difficult to pin down. It is now legal. It's been legal for the past 3 years, and there is a regulated system around it, but it is unlicensed, and patients must be aware that this limits the understanding we have, and they have to take a certain amount of responsibility for the fact that this isn't a well-researched area, that it may not actually treat their underlying illness, and that if they do get some symptomatic relief, potentially that may lead to dependency and other risks and side effects. So we have to acknowledge those harms, but according to the way this has gone in other countries, the medical demand in psychiatry and in medicine in general will increase. So we have to recognise it for what it is, but it is here. I think that's why we have to now update our discussions with our patients, and we have to make sure that research into the appropriate risks and benefits is a priority. I'm really looking forward to the coming years as a time for for research, reflection, and possibly using these medications as part of our arsenal. So, diolch yn fawr, thank you very much.
We've got time for a couple of questions.
Professor Nutt royally was fired from his position because of this very issue that, you know, he dared to say that alcohol's quite dangerous and other drugs may not be as dangerous as those. Certainly, if you were to use cannabis in lieu of alcohol, I would say that it's probably a safer option. If you use it as well as alcohol, that's probably a much less safe option. Interesting, there's been some studies on CBD in addiction and has been shown to reduce nicotine and opiate use, and potentially there could be a role for it in other addictions. So yeah, that's quite an exciting area if that proves to be the case. Within the NHS, you know, we rightly adhere to NICE guidance and, you know, with their quality assured life years, and the standard of evidence for that is particularly high. I think that between that level of evidence requirement and snake oil, then there is a gradation. You know, the evidence base must come from somewhere, and as an individual clinician, if I believe that there is a sufficient evidence base for a patient's condition and they wish to have a trial of this, then I think, based on that risk-benefit analysis, that in certain situations it's ethical to do so. And potentially having a medication that was prevented from being given to people because of 50 years of prohibition is a particularly unethical stance to have happened over that 50 years. That, you know, there may have been people who could have benefited from that and were prevented from doing so, with potentially fatal consequences. And the suffering, particularly within the pain-based community, again, is intolerable. People use fewer opiates when they have prescription of medical cannabis in addition to that. Yes, I can understand the argument that there needs to be very, very high standards of evidence-based practice, but at the same time, there is a patient demand and anecdotal reports of significant benefit, which I find very difficult to ignore. So yes, the clinic was set up in November of last year, so it's only been going a very short time. This was set up following, really, I suppose, a personal experience with medical cannabis. My wife is a medical cannabis user, and she, as a result of the change in legislation, became a legal user for her condition, and she finds that of benefit. So it's a personal anecdote, and because I felt that she benefits from that and I wish her to have medical cannabis prescribed, you know, I felt almost morally duty-bound myself to act in my position to be able to offer that service for other people within my sphere of expertise. It is a personal reason why this company has been set up, and it is a very small company. This is set up from a small base of clinicians who are wanting to enable patients to get that prescription if appropriate and needed. There are much, much larger companies out there. There are about 16, I think, companies at the moment of various sizes and various specialties within those, which are now offering, you know, private medical appointments at £50 a pop. And for a private medical appointment at £50, you know, you may query, you know, how rigorous that could be. You know, I couldn't possibly comment. There is a demand of patients, and there are companies there to fill that demand.